هتنقل المحاضرة بعد كده بروفيسور محمد عرابي هيكلمنا عن الباروكسيزمال هايبرتنشن ذا فورجيتن دايجنوز.
بسم الله الرحمن الرحيم. بشكر استاذي الاستاذ دكتور سليمان غريب والاستاذ الدكتور فتحي مقلدي ومش موجود على الدعوه للمشاركه. الحقيقه السيناريو بتاع البلاد بريشر فاريابيليتي اند البايل بلاد بريشر is one of the difficult situations اللي احنا ممكن نواجهها في البراكتس. Most of the literatures available for the time being does not answer the question of how to manage, how to diagnose, and the problem of blood pressure variability. Here I am going to present a case. This will be a case-based format, interactive. I may ask questions and you answer that address the problem more florid form of blood pressure variability with the paroxysmal symptomatic hypertension. This is the case. A 45 years old premenopausal lady with irrelevant past medical history. During the last 2 years, she had repeated bouts of rapid onset, severe headache, flushing, chest tightness, and palpitation associated with marked blood pressure surge up to 220 over 130, measured both at home and at hospital. Particularly and very importantly, there was no specific psychological or emotional triggers for this paroxysmal attack. She cannot relate this to any triggers, emotional or non-emotional. Blood pressure measured between the attacks was normal, with normal average daytime blood pressure on ambulatory blood pressure monitoring. Repeated medical consultations and lab workups all were unrevealing, and more recently the attacks become more frequent every few days with exaggerated physical symptoms. Her psychological or psychosocial history was remarkable only for remote psychic trauma related to divorce 5 years ago. This is the only remarkable psychosocial factor that was reported, but she did not report any emotional triggers or emotional symptoms at the onset of her hypertensive paroxysm. So the bottom line, we have a premenopausal lady with severe symptomatic paroxysmal hypertension associated with marked physical symptoms. And of course, when this is the normal human blood pressure, it is variable from moment to moment, from day to day, from season to season. But the question is, when this blood pressure variability and the blood pressure liability is actually as a clinically meaningful and deserve clinical reactions. There is no answer for this question in the literature up till now, but the consensus is that when the blood pressure liability fulfilling this criteria, this should be addressed and should be treated. If the blood pressure variability is extreme, if the blood pressure surge exceed 210 millimeter systolic, if it is associated with troublesome physical symptoms like we have in our scenario, and if it is associated with vulnerable medical conditions like chronic aortic dissections, cerebral aneurysm, cerebral hemorrhage, Marfan syndrome, and coronary heart disease. Here we should consider blood pressure variability and blood pressure surge and should be addressed and treated. Apart from this, we have no evidence that treating such like variability is clinically meaningful. And of course, when one see such like patients in the clinical practice, this is what is going to jump to the minds. Could it be pheochromocytoma? Could it be panic attacks with blood pressure elevations? Would it be hypertensive crisis, white coat hypertension, or something else? Do you have any suggestion for something else, by the way? Okay. So the causes of severe symptomatic drugs. No, she has irrelevant history for any medications. And there is no specific triggers for this paroxysm actually.
الناس السنسيتيف للصوديوم وكانوا هاي سولتد
ملوحة وفسيخ وكده.
هاي سولتد
ماشي. She didn't report such like history. This is the causes of symptomatic paroxysmal hypertension. The most common is the panic attacks. But much rare cases may be pheochromocytoma, renovascular hypertension, hyperthyroidism, and postmenopausal symptomatology. Migraine can be presented such like picture. Hypoglycemia, neurodegenerative disorders like Parkinson's, brain tumors, carcinoids, and cocaine use can be presenting in such like picture. But one of the forgotten diagnoses, and even somebody may not hear about it, is the consideration of what we call pseudo-pheochromocytoma. Pseudo-pheochromocytoma. This is much less common than the panic attacks, but it is more common than pheochromocytoma itself. Pheochromocytoma, we should keep it in mind. For sure, it is the first thing to come to jump to your mind when you see such like a case with severe symptomatic paroxysmal hypertensive surge. But actually, it is very rare. It accounts for less than 1% of patients with symptomatic paroxysmal hypertension. And this can be practically excluded by a negative biochemistry. And actually, for our patient, her workup for pheochromocytoma, including the 24-hour urinary metanephrines, were negative. The panic attacks are the most common cause of paroxysmal symptomatic hypertension. This accounts for almost 40% of the cases of symptomatic paroxysmal hypertension. And this is the criteria of diagnosis of panic attacks. By the way, I should acknowledge that I borrowed this slide from Professor Mohamed Oraby previously. Panic attacks is defined as a discrete period of intense fear or discomfort that develops abruptly and reaches a peak within 10 minutes, accompanied by at least 4 of the following 13 somatic and cognitive symptoms. And here you have the symptoms: short of breath, dizziness, palpitation, trembling, sweating. But actually, our patient may fulfill these criteria apart from that her symptoms were not marked or triggered by any emotional stress. She did not report any emotional stress at the onset of her symptoms and blood pressure surge. Pseudo-pheochromocytoma, this is more common actually than pheochromocytoma, but less common, of course, than the panic attacks. And here is the characteristic of pseudo-pheochromocytoma. These patients, like our patient actually, it's typical of our patient presentation, sudden attacks of hypertensive paroxysm, severe hypertensive paroxysm, associated with troublesome physical symptoms similar to pheochromocytoma, with no clear emotional triggers. And here is the point of differentiating pseudo-pheo from the panic attacks. Basically, they have negative pheo biochemistry, the urinary metanephrines, plasma catecholamines, are normal. And more importantly, these patients have a deep repressed old emotional trauma. By repressed emotional trauma اللي احنا بنسميه المكبوتة، الأحاسيس المكبوتة. هي العيان بيبقى تعرض ل psychological trauma or abuse like a divorce or something like that, and the patient don't like to express it during history and keep it repressed, مكبوتة أو مخبأة. ولذلك psychological factor will not be clear in such like patients. They don't present with emotional symptoms and emotional factors like the patient with
ممكن يا محمد
panic attack.
اتدخل في الحته دي، بس هي ده البوست تروماتيك ستريس ديس اوردر الحقيقه، ده البوست تروماتيك ستريس ديس اوردر، وده ليه كرايتيريا سكور تاني للدايجنوزس. فهو لو انت قلت ان هي مش نتيجه
طب خلينا نخلص البرزنتيشن ونناقشها.
ماشي.
Actually the distinction between this different spectrum of psychological disorders مفيش clear cut differentiation ما بينهم. إنما this is one of the presentation which actually included under this post-traumatic disorders, but with a specific phenotypes which is definite paroxysms of hypertension and physical symptoms like pheochromocytoma. في كتير من الليتريتشر بتعتبرهم sort interacting، مفيش clear distinction between these categories. So the main differentiation between the panic and pseudopheochromocytoma, as we see here, is the presence or absence of emotional triggers at the time of the presentation. For patients with the panic attacks, they have very clear emotional triggers and the emotional elements at the time of the paroxysms. For patients with pseudopheo, they don't have these clear emotional triggers, but they have repressed all the emotional trauma and psychological factors. The pathophysiology is simply an abnormal sympathetic nervous system activity and abnormal adrenal medullary sensitivity to the secreted catecholamines due to old repressed psychological trauma like the force in our case. The management of this patient is difficult. It has a very prominent psychological background, and the psychiatric consultation and psychiatric input actually is a very helpful and mainstay in this treatment. And the treatment line is not actually antihypertensive as a first line, but first before all is the psychological consultation and psychotherapy, and the role of antihypertensive, I will discuss it. Acutely during the presentations, during the paroxysms, antihypertensive treatment, drug treatment is indicated only if the blood pressure surge is more than 210/110 millimeter mercury. If not reaching that level and the patient has no evidence of target organ damages, can be treated conservatively with just an anxiolytic. The choice of the antihypertensive treatment in such situation, if it is indicated, include IV labetalol, IV nicardipine, or oral clonidine. This is the classic treatment of pseudopheo. Anxiolytics by using benzodiazepine, actually the cornerstone in the management of these patients acutely. For the preventive treatment in between the attacks, psychotherapy is essential for these patients, including the SSRIs, antidepressants, anxiolytic, and the cognitive and the behavioral therapy. The preventive or the long-term maintenance antihypertensive treatment actually is not indicated if the patient has a normal blood pressure between these paroxysms. It is not indicated to use any of this. And if there is a residual sort of hypertension in between the attacks, the use of combined alpha and the beta blocker labetalol is the drug of choice in this situation. Actually, the patient in our vignette had been referred for the psychiatrist who confirmed the presence of old masked repressed emotional background. She was given SSRIs and sedatives, and she was kept on a small dose labetalol 100 milligram twice daily, and the patient improved remarkably. Both the paroxysms and its severity was ameliorated after this plan of management. So in my conclusion is that despite that human blood pressure is normally variable over time, blood pressure lability should be addressed if it is severe enough, if it is markedly symptomatic, and if it is associated with other vulnerable disorders. Panic attacks and pseudo-pheochromocytoma are common than pheochromocytoma as a presentation of paroxysmal symptomatic hypertension. And thank you very much.
Thank you very much محمد. الحقيقة حلقة حلوة خالص يعني very nice case.
هو السؤال اللي حضرتك كنت سألته معلش أنا هو في الليتريتشر ما فيش distinction كبير. It is a wide spectrum and this could be a phenotype presentation of the post-traumatic syndrome, but they label it as a pseudo-pheo because of the clinical similarity between the presentation.
وكل ده تحت السايكوسوماتيك فهو لا it's very excellent case.
واحيانا يا دكتور الفيميلز في السن المينوبوز بيكونوا برضو فيري فراجايل لاي يعني اريتيشن كده سايكولوجيكال يخش في برضو نفس المنظر في فتره وبتكون بالتالي هرمونال برضو امبالانس.
هو الموست كومون بريزنتيشن اللي بيجي هو البانيك اتاكس. بس الديسيفنج في الحدوته دي ان البانيك اتاكس يوجوالي البيشنت بيبقى عنده ريماركابل ايموشنال سيمبتومز از تريجر يعني العين خايف مقهور حاسس انه هيموت حاسس. انما السودو فيو may not present by such like symptoms كلها physical symptoms and no clear cut وده اللي بيخلي الديسيجن ساعات صعب يعني due to repressed emotions اللي احنا قلنا عليها دي.
اوكي انا بس عندي سؤال بعد اذنكم. اولا مش سؤال يعني انا عندي كومنت. وطبعا we have to put this case a very nice case طبعا. نحط فكره ان العيانه كان عندها palpitation. فالبالبيتيشن دي نقطه مهمه. ليه نقطه مهمه؟ لانها هتخمنا تفكرنا نكون دوت في اتجاه الفيوكروموسايتوما. هنا احنا برضو we did not make a clear distinction between panic attacks والسايكولوجيكال تروما اللي ادت لهايبرتنشن بنسميه احيانا سودو فيوكروموسايتوما. مش قادر احط a clear distinction between the two. يمكن بقى ان حد سايكولوجيست يساعدنا ويدخل معانا في القصه we can be giving يعني ايه يعني نحطها كديفرنشال diagnosis either this or that. بس طبعا definitely لما ببص على اي عيانه بقدر اعرف اذا كانت دي شكلها panic attack ولا شكلها a depressed lady ولا depressed person وداخل في other complications يعني. بس عاده الديبريشن لوحده او الناس اللي جالها ستريس عاده they do not present sudden onset hypertension ويروح بسرعه ويطلع وينزل.
هشام يمكن اتذكرت شويه في اليوروبيان سوسايتي اوف كارديولوجي لسه الجديد 25 اللي هي المنتال هيلث ديس اوردر وتذكر فيها 2 questions ممكن تسالهم عشان تعرف. لكن الحاله دي هي اتسمت سودو فيوكروموسايتوما لان فيزيكالي سوماتيكالي هي دي السيمبتومز بتاعتها. لكن هي في الاصل بوست تروماتيك ستريس ديس اوردر وعشان كده السايكاتريست بيعملوا لهم كوجنيشن وايه
يعني you can call it descriptive term. it is not يعني حاجه بتوصف الوضع.
انا بصراحه بصي انا مش شايف ان هي قوي الترمينولوجي از فيري كوريكت. يعني مثلا في حاجه اسمها painful left bundle branch block. ايه البينفول left bundle branch block دي؟ سمعت عنها؟
وعين بيجي له.
انا قصدي ده طلع الترمينولوجي ده من اكتر من 10 سنين وبعدين حد دلوقتي is trying to revive the terminology. I don't think it's a very accurate terminology. ولكن هنا برضو سودو يعني فيوكروموسايتوما يعني برضو
هو طبعا الكلام اللي
very understandable بالنسبه لي.
الكلام اللي حضرتك بتقوله كلام it is يعني understandable ان هو يعني but you can call it ان انت دي sometimes البرزنتيشن يعني you may consider it as a part of the spectrum of the panic presentation but the only distinction ان هي ما بتجيش بالفول بلون بيكتشر بتاعت البانيك. يعني يوجوالي البانيك ده احنا بنشوف العيانين البانيك حاسس له مش عارف ايه ده مش هتلاقي العيان كالم وهادي وكل حاجه. فده اللي هو ممكن يخليك مصدر التسميه ممكن تعترض عليه وتسميه حاجه ثانيه بس جاست.
اوكي دكتور محمد عماره بنشكر حضرتك جدا. احنا بس عشان الوقت ده يعني محتاج ان احنا نختصر شويه